here, so.
Yeah.
My goggles and stuff are somewhere. I think they're upstairs somewhere.
Oh, you guys agenda to welcome Isabella at the start of the meeting. Between the consent agenda and the.
Oh, got it.
And thank you so much.
And they said, get off your feet now.
And so
We're not getting reschedule.
Oh,
But that's,
Yeah.
But I think it's okay.
I'm getting a little,
And I've met Swam and
weather, you know.
I know.
Do things in
Swam once to the side.
Yeah, get things done.
It'll be great.
I think it'll be nice for the next few weeks, yeah.
It's usually, it's just,
Yeah.
we,
I feel like we're talking about.
Yeah, so I have, hopefully, Carrie and Bill will have wrapped up their time.
yeah, they can give it to us at the meeting or.
I'd like it before.
Yeah, so I should,
Yeah.
because I should put their checks ready
Then,
for them,
yeah.
or should I send them out before the meeting?
5:20.
No, not before.
Not before,
Yeah.
okay.
We have to swim.
But they're not gonna come.
Does the whole
Yeah.
thing close at 5:20 or the pool?
But I'm gonna be in touch with Carrie about a lot of stuff.
Right, yeah,
Because especially with Anchorage Dog being open now all winter,
yeah.
just, you know, if that's gonna mean,
Then they have children's slides.
I can't imagine it'll be more work.
Children's
Yeah.
What is their commitment?
Sure, yeah.
And then I'd like to get the computer.
Yeah.
Also to have that over the winter and learn how to work the Past Perfect.
Yeah.
Yes,
I
yes.
guess I've never shared. You're staying inside.
So,
Yeah, I do,
anyway,
yes, I can
we'll
see
work
it
out some
inside.
details. Yeah.
But I don't even know if we'll have to. Because,
Okay.
Morning, Rena.
Good morning.
How are you?
Very well.
Good morning. How are you? You snuck in behind me.
Sorry.
You snuck in behind me.
Right underneath there.
Is this your introduction?
Well,
That slipped off so fast.
These new chairs, these look so fancy.
I know what you feel like. Are these new chairs?
No?
Same. You never rocked before.
Attention to them before.
Yeah.
Well, this is nice. We have the agenda right here.
Sometimes they get traded around too, I think, when other people, you know, come and take over our spots.
do you just want to start there and then we could move to me and then Melissa can come up? I mean, I guess we could have two chairs there. Take it back.
Allison, are these on all the time or do you have to do the push?
That's on.
I think they're on all the time.
Are we ready? Okay. Good morning. I'm going to call our Public Health and Human Services Board meeting to order. I would like to add an item to the agenda. After our approval of the consent agenda, we would like to take an opportunity to welcome Isabella in her new role. So I'm going to add that, if it's okay.
Madam Chair, I'd make a motion to approve the agenda as amended.
Thank you. Do we have a second?
I'll second.
Thank you. All those in favor?
Aye.
Passes. Thank you very much. We will move on now to, well, did that include the consent agenda? I guess I'm,
Madam Chair, I'd like to make a motion to approve the consent agenda.
just to make sure we're clear there, thank you.
And I will second.
Thank you. All those in favor?
Aye.
All right, motion passes. Thank you very much. So now we will move into welcoming Isabella in her new role, and I will let Allison make the introductions, please.
I just want to welcome Isabella to the Public Health and Human Services Department. She's been with us, this is week 4 now. And she's doing wonderfully. She's just rolling right into her new role. Isabella, as many of you know, is coming to the department from Community Center, where she served as the Community Center assistant for several years. So she's up and running, doing wonderfully. with training. There's a lot to learn, a lot of new programs and systems and acronyms and people, but she's doing a great job, and we're so glad to have her on board.
Thank you.
And are you still working up at the community center a little bit?
Right now, I am there only 1 day per week. Kind of, there is a big transformation there. Say Diane Wolf will be done, I think, next week. And there's no replacement for my position yet. So I already trained Sarah Waddell. I spent about 4 days with her. She's doing really good. She's kind of like me, new position. She keeps saying it's a lot to learn. But other than this, I think what I was able to train her, I pretty much taught her everything what I could. But she will be leaving on the maternity leave soon. So we kind of plan week by week. Maybe one day I will go on a half day to make sure everything is good there. Because I do have a lot of training here. But other than this, whenever there's no need for me there, I will be here 5 days per week.
Well, I appreciate that you're being flexible. We did have an extension meeting yesterday, and it was discussed how are we going to make sure things don't fall through the cracks and staffing issues. So I appreciate that you can be flexible with that.
Yes, for sure, because it's kind of, if I would be in Sarah's shoes, I would not like that somebody will leave and not help or nothing like this. So definitely, if there is a need for a little bit few more weeks, I can definitely do it.
Well, thank you for that. And thank you, Allison, for making that possible, and everybody for working around that so we can make sure things get covered. Thank you for that.
So nice to meet everybody, and I will go back to work. Thank you.
Thank you.
Thank you.
All right, next on our agenda then is our staff report from the Wilderness Outpatient Treatment Program. Welcome. Excited to hear from you.
Am I supposed to start? I guess. Okay. Well, Grace put together a PowerPoint that pretty much covers everything I was going to say. Really good. I feel like I should be standing up. No. So what I'm going to do is I'm going to try to keep this brief. If you think I'm going on too long, you can just give me that sign. I want to talk about how I became the contractor here. I think that would be interesting to everybody. What kind of services we provide and how we provide them. I do want to talk about local advantages, the advantage that I see compared to colleagues of mine who work in other parts of the state. The advantage I have working up here in a small community. And then some issues that we had to address because of COVID and how much that has changed the delivery of the kind of services that I provide up here and all throughout Minnesota. So Allison might be able to give you a little better description of how the county came to the point where they were contracting this service out. But what I understand is that at one time there was a CD counselor on staff, was a county employee. And then I don't know why this changed, but the decision was made, oops, I was going to get corrected. The decision was made to contract this service out. The Center for Alcohol and Drug Treatment was hired to provide CD services up here. They came up then 3 days a week, Tuesday, Wednesday, and Thursdays, and then would go back home. I guess that arrangement didn't work out very well, primarily because the people who came up here would change from week to week, and they didn't know the community and really didn't know the people they were working with. And I can understand that because I live here. I know the people that I have in outpatient, and so I can keep connected with them more than just twice a week. And I really learn more about their lives and what it is they're actually struggling with, if they are, or how they're doing well. How I became the contractor here was through my mentor and boss, Harry Swift, who was the counselor here before me. The way I understand it, when they terminated CAD's contract for the services, they were looking to hire someone locally. Harry Swift had been the CEO of Hazelden, so he ran Hazelden for years and years, had a tremendous background in social services, moved up here to retire. He was in recovery himself, active in the AA community, and saw this job was open, and Harry just really never retired, and so he applied for the job and was interviewed. And what Sue Footer told me was that after the end of that interview, she said to him, well, if you're really who you say you are, you've got the job, but we're going to check. Because it was amazing that this guy would be up here and take over this job, and he did. But one of the promises he made to the county was that he wouldn't leave them in the lurch when he retired, because apparently it was difficult to find the right person for this job. I am in recovery myself. I'm sure some of you knew me before I got sober, and I got sober in this community. I went to treatment, came back, had a relapse, got sober again, and was active in AA. And through AA, I knew Harry, I knew who he was, but he's this imposing, respectable figure who at least I wasn't intimidated by. I didn't know him very well. I was kind of reluctant to talk to him, but the job I had then, I was a house painter, and I got that job through AA Connections, and it was a really good job. It was fun, it paid well, but I think it's around 2007 when we had that economic meltdown, suddenly I had winters off, and I just thought that was great. I'd saved my money. I expected to just have fun all winter. And after a couple months, I started to think about what it was I really wanted to do with my life. Did I want to stay a house painter forever? And I didn't. And I couldn't think of any direction for myself. I knew I wanted to do something in service, but I didn't know where to go or how to go about it. So I thought I'd just ask people I admired what they thought I could do. And Harry was one of them. And I was downtown, and I saw this guy. I wish I could communicate to you how much I respected him and was afraid of him. Just was. And I saw him standing outside of Blue Water, and I just had this thought, why not ask Harry? Buy him a cup of coffee and see what he has to say. And then, the child in me was saying, no, don't do that, don't do that. It would be scary. But I did it anyway. I went up to him, asked him to buy him a cup of coffee, and we talked. And he asked me about my background in education and experience. And then he said to me, and remember, I almost didn't do this. He said to me, well, since you got winters off, you could go back to school, you could get the credits you need to become an alcohol and drug counselor, and you could take over for me when I retire. And I was just floored, because that was it. I heard it, and I wanted to do that. And I was that close to not even talking to him. And, that's really a recovery story, because a lot of people in recovery are going to have a story similar to that, where they can identify when their life just changed. And that's when my life really changed, and I'm so grateful. And then I ended up working in this department. I worked in other places. I was once, when I got out of college, I'd gone to get a master's degree, and I got one in interpersonal group communication. And then I got hired to a job I was unqualified for, but I was the best candidate, and that was to build a group home for developmentally disabled adults in Park Rapids and put together a program. But then I had some experience working with developmentally disabled adults when I was in school, so they hired me. I was out of my league there, but I learned a lot and did that job, and so I had that behind me. And I've just completely forgotten why I'm telling you that.
You're talking about that you came to this department.
Oh, okay. So I did feel, I worked in other departments and had other jobs, and honestly, I've never really worked in a department where the staff was so professional and so confidential and worked so hard. People will say to me that they think I have a really hard job, and believe me, I think I have a pretty easy job, especially compared to the work that the people sitting next to me do, and the social workers. Those are difficult jobs, and they work so hard, and they are so professional, and the working relationship in this department is so good. People support each other, and I just want you to know what a good department this is. That's what I want you to know. The services I provide, I do comprehensive assessments, which are in Rule 25, so that's the first step, somebody getting help. I had a lot of consults with families who are worried about somebody in their family, and do what I can to direct them to get the kind of help they need. I operate outpatient treatment, so that's group treatment for people who meet the right criteria for that kind of intervention. Through my association with the drug court, substance use recovery court, I also help facilitate a group called MRT. And MRT was a therapeutic program developed in prisons to help reduce recidivism when people got out of prisons. And but it also focuses on chemical health. And kind of briefly, that program is for people who think the society's rules just don't apply to them. That's really what it's about. And the program is designed to have them learn to follow rules they don't really think are necessary, and to access this kind of moral center that everybody has that's been violated through maybe their criminal activity and also their chemical use. And I really enjoy being in that group. But I'm a facilitator. There are other people who run that group with me. It's not just me. The advantages. Okay, so I have colleagues who work other places in big organizations, and we meet a couple times a year at professional conferences, and then we talk. And they are often just floored to hear that I can call a doctor and the doctor will answer my phone call, or that they call me. It just seems to be a lot more difficult in other areas of the state. Have good relationships with therapists up here who work up here. I answer their calls, they answer mine. We can talk to each other about our clients without waiting a week. The probation is right down the hall. We always seem to have a good relationship with them. The county attorney is just over in the corner. Social workers are all 5 steps away from me. There is a real advantage for me anyway to be local and know the people the way I do. I was going to try to impress you by having all my notes on my phone, but I went right back to paper. There was a question when I don't want to jump on CERT, but I remember talking to the doctors when they were thinking about having their own medically assisted treatment program for people with opioid addictions. And numbers kept coming up. Are we going to have enough people in this program to justify whatever the expenses and time it would take to serve these people? And eventually what we realized is that in Cook County, we're never going to have those numbers. We're not going to have 24 people in the MAT program. But the people who are in the MAT program are our people. They're people we live with. These are our people, and we have a chance to help our people. And we have to maybe just stop counting numbers and focus on delivering this life-saving help. When I was in school down in St. Paul, of course, I knew a lot of people who were going through the same program as me, and they were talking about drug overdoses and deaths, and I honestly, when I was down there, I thought, well, thank God I'm going up to Cook County where I'm never going to really have to see this. And it turns out that we're not immune from any of this. I have met people who have died because they just weren't willing to address their alcohol use. I'm aware of deaths due to overdoses. I worked briefly with a young guy in his 20s who died from complications directly related to his alcohol use. He's a young guy. And when I met him through his doctor. The doctor already said his prognosis was bad, that he didn't expect him to survive. But I'm kind of a kid, really. One of the things, I like to make models. And this kid liked to make models. And so we connected a little bit on that. We could talk about how much fun it was to take a model with instructions and then change all those instructions to create something we really wanted. And so the doctor and this kid's family decided that at least being an outpatient would maybe improve the quality of his life. But he died before he could even get in outpatient. And it's just the saddest thing, because this was, like so many deaths, it was preventable if we could have intervened early enough. This illness, now I think of this as an illness, our profession thinks of this as an illness. There's some controversy about that, and there's controversy in my group about it. And so what I'll tell people is, if you don't want to call it an illness, don't call it an illness, call it it, because it has these characteristics. And one of them is that it's an illness of the brain that manifests itself in a change in behavior. And that change in behavior is often denial. It's chronic, it's progressive, it's a relapsing illness, so we know that happens. And if it isn't treated, it keeps getting worse, and ultimately death in some cases. Maybe in a lot of cases, I don't know. I heard a statistic recently that kind of impressed me, is that when you go home tonight and you're driving around town, you can assume that 2 out of 10 people you meet on the road are probably under the influence of some substance. They may not be drunk, but it is influencing their behavior in their car. Now that's kind of a national statistic. I don't know how it would apply in Cook County, except that throughout the years that I've been here, alcohol has always been the major chemical dependency I've dealt with. Even for people who are maybe come to see me through some avenue like probation or family, and because they're using meth, for instance, or maybe opioids, alcohol always seems to also be prominent. So I've always assumed, I know that I'm dealing with alcohol often, and so I kind of watch the cars when I drive around town myself. And I was one of those people. It's so ironic that I'm working with police officers now who I've been luckily, happily, thank God, sober for almost 18 years. But some of these very police officers used to follow me around. If you know how they do it, they get as close as they can to your bumper and wait for you to make a mistake. And I was followed by some of the very same people I work with now. That's kind of ironic to me, but I was a danger on the road. Luckily, I never had an accident or DUI, but I was a full-on addict. I used a lot of other substances. I really never said no to anything, but alcohol was something that I used all the time. And I can tell you that we will accept any rationalization we can to make it okay to drive on the road or to use. Chemical dependency is an illness that costs people like me a lot. We lose a lot. But there's a phrase that's supposed to be funny in AA that recovery is easy, all you have to do is change everything. And, and there's so much truth in that, because if you were a person like me, my chemical use affected every part of my life. Our lives change to accommodate our use because we cannot stop. I know sometimes that's controversial to hear that we cannot stop, but I'll use opioids as an example to help us, to help illustrate what's going on in the brain. So opioids, people use opioids, heroin's one. It has a chemical makeup that is just so similar to neurochemicals the brain already uses to function normally. It's just so similar. And our brains are protected by something called a blood-brain barrier, and it's meant to sieve out, I think under an electron microscope it actually looks like a sieve. It's meant to keep out anything in the bloodstream that doesn't belong in the brain. But because this chemical makeup of opioids is so similar to a chemical in the brain, it passes through. And then what the brain experiences is a flood of a chemical that it is supposed to be there. But now this is a crisis because your brain is always trying to keep itself in balance. Now it's got a problem because there's a flood of a chemical that is supposed to be there, but there's too much. And so what it will do is it'll begin shutting down its own production of that chemical in order to bring itself into balance. The thing with opioids is that, let me just briefly illustrate this. Our brain is composed of billions of brain cells, which is amazing. And they don't touch each other, but they do communicate with each other, and they all have little fingers. And so this cell is going to send out little chemical messengers to the next cell. If this cell has receptors that are appropriate for this chemical that it's sending, it'll accept them. And then a long chain of cells firing that is going on in our brains right now and in mine as I move around and talk. And so the brain shuts down its production of this chemical, hoping that'll balance it. It doesn't, because it still has too much. So then it acts on these receptor cells and just creates more of them to give all this flood a place to go. So when it has begun shutting down its production, that's dependence. And when it begins creating more places for that chemical to go, that's tolerance. And that's what we see in people who have a chemical dependency. They have a high tolerance because their brain has adapted to protect itself. It's just trying to protect itself. And I am chemically dependent now on using opioids because if I stop using them, now my brain has a deficit. Now it doesn't have what it needs to operate, and I feel terrible. And sometimes, then this is true for all the mood-altering chemicals. If you stop suddenly, you feel terrible. You might feel physically terrible, but you also feel mentally terrible and emotionally terrible. And so, you know, we learn the cure for that is just to have another bump. And then the rationalization that goes in our head is, boy, I know I'm really got a problem, but if I just get back on my feet, I'll be able to address this issue. But the problem is that that isn't what happens. As soon as I start drinking or using again, I want to use more, and we never address our problems. Yes. Oh, changes in connecting. Okay, so COVID happens, and all of a sudden we have to shut down our program. Programs all over the state are shutting down, and there was dark humor in my field. Was if we wanted to create conditions that would encourage addiction and encourage relapse, this is what we would do. This is it. This would be the changes we would make. We would remove people from their treatment groups. We would tell them to isolate. Don't go to your AA, NA meetings anymore. You can't. Stay in your home. Stay away from your family. Stories of people who couldn't visit their families in nursing homes. And the stress associated with these sudden changes really is a disadvantage for people with chemical dependency because, you know, the mood-altering substance, we learn if we don't like the way we feel, we can change how we feel. And we don't have to change any of the reasons we're feeling this way. We can just change how we feel. And so we were afraid there would be a lot of relapses. In my experience, what happened was the people who were doing well continued to do well because they had learned how to change their life enough, make changes in their behavior to avoid a relapse, and they continued doing that. The people who were just starting out didn't do well. If they were on probation, they just disappeared. Probation couldn't supervise them anymore or test them, and they literally disappeared, at least from my group. Honestly, when this began, I thought this would last 4 or 5 months. We'd get back on track, and that wasn't the case. So we had to adapt. And one of the ways I adapted was because I couldn't have groups, I started meeting with people individually. And that worked in at least half the cases. It seemed to be what people needed. I was reluctant to do Zoom outpatient groups because of the way I behaved in Zoom AA meetings. You know, you see yourself from here up, and I'm just easily distracted and bored, and I'd find myself shopping for guitars or on Amazon under the camera. And then I'd hear something somebody would say that, you know, attracted my attention, but I hadn't heard anything that had gone on before that. And I was afraid my clients were going to act this way in Zoom, and I held on to the belief that the most important thing I could do was meet as a group in person. But we couldn't do that, so I had to adjust to Zoom, and it turns out that there are many advantages to to telehealth that I was unaware of. For our population up here, transportation was a big issue. During the winter, I've had people who were in outpatient who lived in Schroeder, who didn't have a driver's license, have to find somebody to drive them, that person would wait here for 2 hours and then drive them home, and they had to do that twice a week. In the winter, driving conditions can be bad. I would always tell people, don't use your own judgment. Don't drive if you think the weather's bad, knowing I was giving people an excuse, but it turned out they didn't abuse that at all. And people would drive through weather that I thought maybe they should have stayed at home. But so anyway, and a lot of clients in Grand Portage who have the same situation. When we were having group live, Grand Portage had a grant to provide transportation, so they were coming and going as a group in a car that was paid by the grant. But transportation is a problem up here, and with Zoom meetings, they just don't have that problem anymore. People can attend group. So my job is to make group worthwhile under these new conditions. And it just turns out that people in the group do continue to make these personal connections with each other, even though they may not ever be in group together. I have more control over the group, which is something I like. In the past, I would have to make copy after copy after copy of something I was going to present in group and give it to everybody. And, everything always changes in group, and so some new issue would come up, so I'd have to take a break, make copies, and bring them to everybody. Now I can just pull stuff up on a screen, whenever I need it. And it just turns out you can do good therapeutic work on Zoom, and I didn't know that. So that was how we were affected by COVID, and I don't think telehealth is ever going to go away now. I think it's here to stay in some capacity, and I'm grateful for it myself. I think that might be everything I have to cover. Not everything I planned to say, but everything. But I sure have talked long enough, so thank you.
Thank you, Greg. I really appreciate everything that you shared. And as far as being a team, all of this work takes a lot of integration and time and communication, but mostly care and compassion for individuals who are suffering and struggling with a disease that needs to be addressed. And I think,
if you're like me, you probably have people in your life who you know and love who have struggled with some way, shape, or form with chemical health, and you've experienced the struggle and the frustration and the fear that Greg described. And so we're talking now about the things that how can we provide structure, because we as individuals can't do things alone. We have to work together. And so I think a really huge step forward in the whole world of support for people with chemical health struggles is Substance Use Recovery Court. And there's nothing new about substance use recovery courts. They started in 1989 in Dade County, Florida, because there was a lot of rules about how long somebody had to stay in jail if you were arrested with drugs or with drugs on your person and such. And the jails were just getting clogged up, and nobody was changing, and there was so much recidivism. And so there was this new model that came forward, Substance Use Recovery Court. And I know some people call it drug court. That's what it was called earlier on. And we've changed that acronym now to Substance Use Recovery, or SUD, you might see us say. And the model is very, very integrated and collaborative across multiple systems: healthcare, law enforcement, the judicial system, behavioral health, and chemical dependency counseling. And it's a very effective model, and it's evidence-based. We have gone to multiple trainings in the region for Substance Use Recovery Court, and I can tell you that our trainings are conducted by psychiatrists, psychologists, judges. People are so committed to this because it's so effective. And so in Cook County, we started they started planning for Substance Use Recovery Court in 2016, and I think we really got up and running in 2018. And so it's a very formal process for accepting somebody. A person who is accepted into CIRC has to have completed a assessment tool called a RANT, and what that does is it assesses for high risk of recidivism of crime and high risk of relapse of use. And so if those two variables are met, and then they are accepted into CIRC. And CIRC has, it's approximately 18 months long, and there's a lot of structure to it that helps a person in their recovery. And it's a really beautiful model, and it's really effective. And there are people who've completed CIRC who are in recovery who we thought would never recover, and it's really exciting to see how effective it is. It is, so in Cook County, I just want to say right now, in 2019, Cook County and Lake County have combined to create what's called the SHORE Substance Use Recovery Program. And so when Greg talks about doing his MRT program, he does that program with participants from Lake and Cook County who are participating in the CIRC program. So CIRC has court every other week. We meet with people. We check in and see how they're doing. This is how deep the research goes with CIRC. Somebody did a time motion observation in courts to find out how much time a judge needed to talk to somebody to have an effect on their behavior. And they determined that a minimum of 3 minutes of one-to-one contact with the judge, giving them that individual positive feedback, has a positive outcome. And so that just tells you the power of the system. But you can imagine if you're a person who's committed a lot of crimes and has a lot of fear of the judicial system because of the powerful effects of that system on your life and your family's life, if a judge actually spends 5 minutes talking to you about your life and about fishing and how they're doing and how to do better, and it's really astounding. And I can't say enough about Judge Kuzo. He's just amazing. He's just been, especially during COVID, he's just really been so encouraging in telling people how brave and strong they are to move through this really difficult time while they're in recovery. So Judge Kuzo does an amazing job. So why do we need CIRC? Because, as I said, there's a lot of crimes that are committed involve drug use and chemical use, and because if people who commit crimes and have substance use disorder go to jail, half of them are rearrested the first year, and 2/3 are rearrested in 3 years. So jail doesn't help you stop your substance use disorder. We know that treatment is what is effective. So the CERC participants, they are supported through structure and accountability. The first step is often just showing up and making sure that they show up on time. As Greg said, a lot of people that are in the MRT class just feel like the rules don't apply. Well, the system hasn't really maybe worked for them in the past, or they've just learned that that's their survival skill. So just showing up is a really great step, and meeting with court people. And it can be kind of intimidating when we met in person. The judges were in the chambers, and then, there's the chief deputy is there, and Greg is there, and probation officers are there, the county attorney's there, and it's a lot of people having expectations of individuals, and these people are usually individuals that they were fearful of or felt threatened by because of their behaviors and choices and how things had gone down. But it's a really great team, and we really, I so appreciate everybody on it, the honest communication. Just to be clear that there are releases of information so that when a person chooses to participate in CERC, they realize that all the people on this list will hear the information. That's part of the process. And one other variable, not only does a person need to be high risk for recidivism and high risk for relapse, they also need to have committed a crime that could allow them to be incarcerated for at least a year and 1 day. So instead of going to jail, you participate in CERC. And you have this structure, but it really is great because it really allows the person to stay in the community. You can keep your job and go to CERC every other week, versus if you're gone from the community, you aren't earning, you're incarcerated, you're not earning any money, you aren't seeing your children and providing them that support, and that's very traumatic. Kids who have parents who are incarcerated really feel the effects of that, and we contribute again then to that cycle of people being harmed. People experience long-term recovery by staying in the community and participating in CERC. There aren't a lot of treatment recovery stories from jail. And in fact, some of the rules related to recovery in CERC are that the learning only goes one way. If you put somebody with who's really doing a really great job in their recovery along with somebody who's really, really struggling, the learning generally goes towards the person that's really struggling. I think we think, people will learn by good examples, but the research, and I really trust the research that the CERC community does, is that the learning goes one way, and so you have to be very careful about who you let into the groups and for what's the best fit for the group, so that people recover and we allow the best chance for recovery. One other thing too is in larger communities, they're able to divide, there's multiple groups. There's Veterans Recovery Court, Substance Use Recovery Court, or women and men are often divided into different groups because oftentimes when using, women are vulnerable to being sexually exploited, or they trade sex for drugs, probably with some of the same guys that are in the group, the CERC group. So to be mixed in a mixed group, that is really a challenge to your recovery, because those are really devastating experiences for the individuals in recovery. So to place them together is not effective and doesn't contribute to recovery. And so I just want to say that Substance Use Recovery Court is one of the best things I've seen in the field of recovery ever. It's so compassionate and structured and wise, and I really appreciate everybody on that team and what it's done for our community, and I'm so thankful for that. And one of the other emerging things in our team, which I'm so thankful for, is the substance use disorder case management. This is something that we've tried to do for many years. I've been here for like 15 years, and we've only done it very poorly because we didn't have enough staff and we didn't have somebody dedicated to that need. But as we've grown and as we've learned, it's clear that people need more support and structure to recover. And we don't want to keep sending people back to treatment, or we don't want people's lives devastated because we can't provide them with enough support and structure. And so I'm so thankful that Melissa is here, and I'm going to hand it over to her and, as she talks a little bit about how case management can be another component of support that helps people in a long-term recovery.
Okay, so Grace, I'm actually going to work backwards from this. So
Sounds
you
great.
Go home, forward a couple. So-
Yeah, I'll do that.
So my background, I'm a clinical social worker, so I want to give a little bit of insight as far as education, because this population that we're working with who have substance use disorders can be exhausting at times. We can lose our empathy who we're working with. And this is the picture that's on the slide, and the reason why I give it to you too is because it's nice to have around. Because although it says how trauma can affect your window of tolerance, we all have trauma. Would you guys think happen? All right. So we all have trauma, whether it's a small T or a big T. We've lost an animal maybe along the way. We've lost a parent, a grandparent, family, didn't get a job. We all have trauma in our life. So when we remember this, when we're dealing with this population, this window of tolerance in the middle here, this picture of the beach scene, is where we all strive to be. Okay, this is where we're like a duck. Something happens, it rolls off our back. Okay? Our window of tolerance in this room between all of us are really vastly different. So my window of tolerance can be this size maybe. Allison's may be smaller. Someone may have, non-existent window of tolerance, meaning there isn't a time in their life during their day where things feel in control. Something may happen and they feel like they can deal with it. Okay? If there is no window of tolerance, there's two places you can go. You can go to hyperarousal, which is this volcano picture on the top. And so this is where you may be anxious, angry, quick-tongued, just really reactive. This is also that fight or flight. Okay, so our nervous system's offline, our brain is offline, we are in survival mode, we are doing what we have to do to get through. Okay? A lot of times this is where individuals who we're working with live in. Okay, and then when they're not there, they shut down, okay, because it's exhausting to be in that hypervigilant state, and so they go to this hypoarousal. This is this frozen, numb, I can't get out of bed, I can't go to the grocery store, what is showering, what is doing my daily habits? And it's common for people to go back and forth between if they don't have that window of tolerance, okay? Things that may affect this, some vulnerability factors, could be substance use. It could be a history of trauma in the family. It could be generations of substance use in the family. It could be poverty. It could be lack of education, right? So there's maybe lack of sleep, homelessness, food insecurities. So these are the things that are going to affect our window of tolerance in that time when we're feeling like we can really do our work. Unfortunately, if we're landing between hyperarousal and hypoarousal, between the fight and flight and freeze state, we can't do any work. So we can't do any therapy. We can't process what's happening because we're offline. We're trying to survive. So this is where case management comes in. Having an advocate for someone and someone who can sort of sort out those different pieces in the community, okay, is where it's key to have this case management piece, especially for those who are sort of offline, really living between that hyperarousal or hypo. The other piece of this is how are they coping when they're outside of it, because they're not using their sort of right mind or, how do I survive? Sometimes it's using these coping mechanisms as alcohol, drugs, all of that, which is going to keep sort of in the system. So where I come in is that I, am the connection between pre-treatment, during treatment, and then after treatment of connecting to resources. So thankfully, we have some great resources here that I've discovered. For example, Rosa's Pantry is willing to set aside some boxes for me so we can help distribute food to those who cannot get out of bed to go get food, cannot activate to go do the things that they need to do. And so case management is really able to help sort of connect with each person, identify their needs. It could be external, it could be housing, it could be maybe education. It could be internal, it could be setting up someone with therapy, it could be learning daily skills, it could be how do I learn about the window of tolerance and activate, how do I change something in my day-to-day routine to live differently, okay? It could be setting up with the outpatient wilderness group. So case management really just navigates what's out there because someone may not know or have the capacity to activate, to understand, or seek out those resources. So the difference between case management and therapy is really case management is just resource acquisition. How can we help connect you, okay? Therapy is more about the interpersonal changes, intra or interpersonal changes. How do you sort of go through, process what you're going through? So they are a little bit different in that way. Because we know up to 70% of individuals with substance use disorder have a lifetime history of depression. So mental health and substance use really go hand in hand. And so thankfully, I'm so happy to be here and use my background of my therapy, clinical skills training, and to combine it with the resources has really been helpful so far. For example, we just had a kiddo placed in treatment who has family, who's been through it. First time away from home. Do you know how many visitors he's had? 1. Me. Okay? So that's the importance of this position in this community of sometimes what someone is going through can exhaust and burn out all of those connections with family members, with their community members, with their friends. So to have a place and have a resource that really is just being their advocate, being someone to support them through the process is super important and also builds that connection of hope.
Okay.
That's us.
Great.
Yeah.
So just to, right now, Melissa is in here 3 weeks.
3 weeks and I have a caseload of 12 already.
Yeah, so which is really exciting. And all those who are participating in CIRC are referred to Melissa. People who are on the medical assistance treatment program at Sawtooth Mountain Clinic will soon be connecting when appropriate to Melissa. And then just those who are, anybody who's recommended for inpatient. So thank you all for your time. I know we've shared a lot, but we're just very excited about what we're able to achieve in our tiny little community with such limited resources to help the people that are here who need our support. So thank you.
Thank you. I really appreciate the detail you've gone into explaining things to somebody like me that is really confused by everything. And Greg, I just want to say, I really appreciated you sharing your personal story and excited about Zoom because I will tell you, I was also a skeptic. I mean, I've been through therapy on numerous occasions, yeah. And I just thought there's just no way you can connect on Zoom. So I'm glad to hear that it's working well for you. I still think some people like me prefer in person, so I appreciate that you did that also.
Yeah.
So
And
I appreciate
say, the group is broken up. How am I going to say this? Well, like tonight, I will meet with the people who are in this area in person and Zoom with people in Grand Portage. And then Thursday, I'll be in Grand Portage in person with them and Zooming the people at this end. So we were finding a way to, I think you're right, I think I'm right, that we need to be connected in person with these people as much as possible.
So I appreciate the work you're doing to make that happen and make this all work. If you don't mind, I'm going to ask a couple more questions. Just first, WOTP, what does that stand for?
Oh, sorry, Wilderness Outpatient Treatment.
Okay, that's what, all right. Just want to clarify that I didn't miss another acronym.
In a world of acronyms.
I know. And I know you didn't like numbers, but I'm curious a percentage of women versus males and
Well,
in your
talk? Sure. So, can I talk? Yay. When I started here, our outpatient program was primarily male. It was rare to see a woman in group for some reason. Now, easily half and half and sometimes more women in group. And we've had to adapt to that in positive ways because so many women I work with have been victims of domestic abuse that we will not admit a man who has a history of domestic abuse in order to protect that those people, make it comfortable for them to be in group. You know, small community, either really do know each other or we think we do, but, you know, it just is not something we can do. So anyway, women make the group better.
Well, I think so.
Of course.
It's 50-50 though.
Yeah, it's 50-50.
It's a split, I would say.
Yeah.
And then age, I mean, as young as 19 and as old as
Yeah.
80?
Yeah. It's surprising how many people I meet who are as old as I am who are discovering their first chemical dependency issue. But as people get older, your tolerance goes down. And so, you know, 3 beers in the evening might not have affected you very much when you were 40, but at 70 or 80, now you've got a DUI and you can't understand why, and nothing has changed as far as you're concerned. So, you know, yeah, we have all age groups, and we just put them together.
And would you say the cases that are coming to you, are they coming from probation? Are they, signing up, they're self-referred, or?
There's always a mix of people who were referred by probation and people who are there voluntarily. We always have a mix. It's usually more in probation. But one of the jobs of treatment is to enhance people's motivation to get sober. And so they may come unwilling and not thinking they have a problem to deal with. Our job is to help them see clearly what the consequences were of use, and so they can make a decision whether or not to address it seriously. During COVID, it was interesting. I started getting calls from people who were self-referring, who were worried about their drinking because they could see their drinking escalate. In their minds, they'd never had a problem with alcohol, and they were worried themselves. And some calls from families for the same reason. So that was interesting to me, and hopeful that people could reach out for help. There's such a stigma around chemical dependency. There's such a stigma around mental health, that keeps people from seeking help. But I like to think of myself and yeah. 3 weeks.
It's only been 3 weeks.
It's only 3. And Melissa, as people skilled in helping a person with a particular problem. When your car breaks down, I don't try to fix it myself. Take it to Tire and Auto, and I have some sort of psychological issue, just go to a therapist. And it's an objective person who's seen it before, who has suggestions that might help.
Well, thank you.
It's not shrinking.
So, Melissa, I am totally impressed with your job and what you are responsible for. That's another issue that I never really thought about before, so I appreciate you sharing. That must be high burnout, though. How long do people like you stay in your positions?
That's a great question. I don't know. That's half of what we learn, though, right, is self-care. That's why I'm here. That's why I love the Great Wide Open. That's why I go for hikes at night. It's all about taking care of ourselves, because if we can't take care of others. So it is something we know and learn, and it's aware. And when you have wonderful people who you can communicate with of, like, I needed an afternoon off, you really just have to advocate for yourself as well.
Okay, well, yeah, I could see where that would be extremely important, so thank you for what you do.
Mm-hmm.
I'm sorry for just jumping right in there.
You're the
other
chair.
commissioners.
You're the chair. You can do that.
I like to, go last usually, but no, I just really appreciate the work you're doing, so I want to express that.
I appreciate everybody's interest and support.
Yes.
Yeah,
go ahead.
I would love to just keep talking about all of this more and more, and just I have butterflies in my stomach just because of how exciting it is and how important it is for our community and just our whole society, regionally, nationally. I mean, and just how it's all connected, starting with ACEs and that trauma, and how children's window of tolerance shrinks through that, and if they don't have proper ways of expanding that window of tolerance, then it can go just between the hyperarousal and hypoarousal, and then of course chemical dependency fits into that, just dealing with that shrinking of window of tolerance, and so it goes on, and I really appreciate learning about the neuroscience and how things work up in there. And I'm sure people in group appreciate that as well, even if it's not all grasped, just learning about the reasons of why these things are happening and how we can better address that. I just really appreciate you pointing that out. And so one of the coffee sessions with AMC had a neuroscientist from the U of M who specialized in addiction. And it was really fascinating to hear about that. You know, chemical addiction is one thing, but there's a really fine line between any addiction. And once you establish those addictive pathways, it can very easily turn into chemical addiction. And there's also good addictions. You know, we can be addicted to outdoors and sunshine and love and joy, and really trying to establish those neural networks are really important. And so I appreciate, you know, hearing that Judge Kuzo is really trying to bring those positive pathways and reinforcing that, and that's really exciting. But yeah, it's you know, I think I hear what you're saying, that we'll never necessarily have the numbers in Cook County, you know, for the chemical addictions, but I think we should keep in mind just the other types of addictions too, and that I think just recognizing that and dealing with all those traumas, whatever level they are, it's all part of that discussion. So I think even if we don't have the chemical addiction numbers, we certainly have other addictions, whether it be video games or you know, social media or whatever. You know, it's all very similar. So and I'm just really grateful for the work that you're doing, and really excited for what we're learning about too, just with modern research and just better tools to do that. So thank you for your work in our community, and yeah, that's that.
Thank you.
Any other comments or questions? No? All right. Well, thank you very much for your great presentation.
Thank you.
Thanks for making it comfortable to do this.
All right. Next on our agenda, we have Grace to give us a report.
Just back to Google Chrome, that'll bring the agenda. There it is. Oops. Yay, there. Thank you so much, Grace. Thank you.
All right. Good morning, everyone, and thanks for having me back for another update on COVID. So our case count at this point is 251, so it's gone up 32 since our last PHHS board meeting on September 21st. Our trends in terms of cases continue to mirror trends for the state, and I can link to the the weekly trends that the Minnesota Department of Health puts out. The most notable, I would say, is an uptick in youth cases. So of those 32 cases since the 21st, 12 of them have been youth under the age of 18. We have had cases that have attended youth programming like school while infectious. And thankfully, we've developed really strong partnerships over the course of the pandemic to be able to work with our schools when we have a school-linked case and do the follow-up contact tracing in collaboration with our partners at local schools. So case investigation, contact tracing, we're continuing on providing that service in collaboration with Grand Portage Health Services, and this has just made a huge difference in our response. Basically, it gives us the opportunity to provide information about the isolation and quarantine recommendations, to connect people with testing, and then to really answer people's questions. I think that's one of the most valuable aspects of providing that service locally, is that we're able to connect and just give people the opportunity to feel like they know what it is that they should be doing, because it is complex. There are a lot of dates thrown out there, and there are some real questions about, what it means to stay home. And thankfully, in working with our partners at Grand Portage Health Services, we're able to connect with, I would say, over 90% of our cases at this point, which is really quite remarkable. I learned at the state level that percentage is closer to 30%. And so the fact that we've been able to make those local connections and calls in a timely way, I think, has been really valuable in the response. Testing. So there's an increased demand for routine weekly testing in schools and daycares. And that demand for routine weekly testing is likely to increase, as I'm anticipating local employers might need to provide routine testing opportunities for unvaccinated employees at some point in the future, or they may opt to do so. So the reason for routine testing is essentially it's a public health strategy to lower the spread of the virus, because we know that cases might not show symptoms, but they might be able to still be considered infectious and pass the virus along to others around them. So it's really a public health intervention to slow the spread of the virus. So ISD 166 has indicated in conversations with us that they're interested in public health partnering with them to improve access to routine testing on site. And so we're currently exploring what that partnership might look like. It may involve adding a very part-time temporary staff to be able to expand that capacity for test specimen collection. And ISD has indicated that if we do go that route, they would have grant funds available to support that partnership. So in addition to testing, vaccination planning has been a huge part of our workload in the past month, and that will continue for the next few months here. So right now, we're able to offer the flu vaccine alongside the COVID vaccine, whether it's a first, second, or third dose of COVID vaccine. That's something that the nurses are able to offer. So at this point, we continue to really stress what we call the primary series, so people who are getting their first or second dose of the Pfizer or Moderna vaccine. That is what makes the biggest difference in terms of how well vaccination slows the spread of disease. People who are unvaccinated getting their primary series of the vaccine. At this point, there's also a recommendation for a very select group of people with immune-compromised conditions to get a third dose. And I mention this because we're also going to talk about boosters, and they're actually two different things. So for the immune-compromised group, the recommendation for the third dose is because people living with immune-compromised conditions may not have created a sufficient immune response with 2 doses, so they're recommended a third dose in order to get full protection from the vaccine. And that's different from a booster dose, which is basically a response to strengthen that full response from the vaccine. And that's where we hear that there may be what they call waning immunity after a certain point of time. So if we are starting to see that there's waning immunity, so what that means is you still have really strong protection from that severe outcome, but you see the protection from disease at all wane slightly after 6 months. So for Pfizer at this point, FDA and CDC have recommended booster doses after 6 months for people 65 and up or who have certain high-risk occupations or living settings. So people, for example, in long-term care who are living in a congregate setting, such as a group home, those would be people who fall under that recommendation. At this point, it's only for Pfizer. But we know that the CDC at some point this week is going to come out with a booster recommendation for Johnson & Johnson and Moderna. And at that point, because we've primarily vaccinated with Moderna in Cook County, we're going to have a large group of community members who likely, I think the criteria are likely to be similar for Moderna and Johnson & Johnson as they are for Pfizer, but we don't know yet until the CDC meets later this week. And at that point, we're just going to have a huge eligible population for those booster vaccines. So we're doing pre-planning with the clinic to see what we're able to staff to meet that demand in early November, perhaps even late October, depending on the timing of the CDC announcement, which I'm assuming could come as soon as this week. And it will be, if what I've seen from the initial conversations is that the actual vaccine product will be different. So we're dealing with a number of different vaccine products and staffing events to be able to meet demand from eligible populations locally. So we're kind of going back to when we think about the March, February days of vaccine planning, when we did those quite large events. We're planning for that size of event again. We're also looking for so it's next week on the 26th will be the first in a series of meetings about recommendations for vaccination for youth 5 to 11. So I'm imagining the first week of November is as soon as we might see recommendations come out for vaccinating the pediatric population. And so we're also planning for pediatric vaccination opportunities, as well as education and an opportunity for parents of children in that age group to ask questions that they might have about those vaccines for children. So a lot is happening in the world of vaccine planning. That's where a bulk of our, I would say our time is kind of split between the contact tracing, planning for increased testing, and planning for increased vaccination in the coming months. So things have been busy. But they're exciting. It's really exciting to be talking about vaccination for youth 5 to 11. I think that will make a huge difference for our schools and our school families. And so that's just really good news. We also continue to get requests for technical assistance for infection control. At this point, it continues to primarily be for event planning. So large events, event planners that are looking towards what it might be like in the late fall, early winter, those tend to be the requests that we're getting at this point. We do have the hub updated with weekly case counts at this point, and we are planning to do a breakdown of case data by age range on a monthly basis at some point in the near future. Also accompanied by a weekly COVID safety tip that we plan to post to social media as well, to try to just be proactive at getting some questions that we've heard come up answered in a more public form, so that if people have them, usually if someone asks a question, more than one person has it, and social media posts are one way to get that kind of information out there. I'll also be back on WTIP next Monday morning, and we're really in collaboration. A lot of our communications efforts, I think, will be focused on vaccination at this point. So as soon as that news comes out about booster eligibility, there'll be a media release, we'll make updates to the hub site, and we'll really try to make it as clear as possible for community members who have questions about those boosters. And then shortly after, we'll follow that with news about the 5 to 11 vaccination. So that's, I think, going to be the focus in the near future. And that's, in a nutshell, kind of what we've been working on in the past month here. Happy to take questions from the board, and thank you again for inviting me to give an update. I'm always happy to come down and share what I know.
Thank you.
Commissioner Storlie.
Thank you. Thanks, Grace. Always appreciate your updating. We have 2 events happening in the West End, and I hope you've been contacted about that. One is when Senator Bach and Eklund are going to be here, and the other one is going to be evidently some type of event up at the ski hill. I don't know if it's Papa Charlie's or Moguls. How do you handle something like that? Do you say only a certain amount of numbers, or how is that handled?
You know, at this point, it's really an opt-in. So I would encourage the organizers to reach out to us in public health, and we're happy to connect with them. But unlike earlier in the pandemic, where there were kind of more restrictions coming down from a state level, at this point it is up to the discretion of the event organizer. So our role is really to help look through the plan that they have and provide feedback on areas that would be of particular concern in terms of infection control. So some examples are whenever there's eating and drinking, that's a big one that we look at. We talk a lot about kind of indoors versus outdoors and whether there's a way to collect names and phone numbers of attendees in case there were to be a positive case and we needed to reach out and let people know they may have been exposed. So we go through a number of considerations, but at this point it really is up to the discretion of the event organizer. So there's not, sometimes a venue will put like a recommendation that people using a space will connect with us, but there's not, it's really an opt-in at this point. So there's not a requirement to work with us, but we certainly are always happy to talk with folks.
Great, thank you.
Commissioner Sullivan.
Yes. Question I had is, what do you attribute our really excellent contact tracing to? We have 90% versus the state at 30%. What magic do we have here in Cook County?
I think that some of it is on the kind of system and the staff, but also the community just being comfortable talking to us and answering those calls. I think it makes a difference that there are local people who are making those calls. In some cases, communities have kind of outsourced that function to the Minnesota Department of Health, and they do a great job, but I do think it makes a difference to have a local number and, that local connection to try to help them set up a test. And I think that's a big part of it. Early on, we tried to have contact tracers introduce themselves like on the radio so people could hear their voices. I think we've just tried to really make it a localized system and a supportive system too, so that we can, I think those connections also, for example, all the work we've done to build that relationship up with our schools. When we have a case in the schools, we have a pretty seamless process to work together to know who we need to be contacting, to also answer the school's questions, and then the school can ask us questions about the process, so we all kind of have a common understanding of what we're doing and why, and we can talk to families about it. I just think it's valuable, and I think we owe it to the community to give them an opportunity to have their questions answered too, because there's a lot of questions, particularly if it's a household where there's multiple people, and sometimes multiple people with multiple vaccination statuses. It can get confusing. So we try to do really robust follow-up too. We always ask if they want an email so that we can write down the dates and recommendations. Sometimes it's hard to just kind of integrate everything in a phone conversation.
Well, thank you just so much for all the effort and the skill you've used to keep our community safe and to help prevent the spread.
Thanks. It's our pleasure.
Anybody else have any questions or comments?
A quick one. Are you able to say where in the county are there hot spots, so to speak? Are there places?
I think, so part of that like weekly tip is kind of an attempt to get at that in a different way. Because I think we do see, it's not necessarily that there are hot spots per se, but there are types of situations where it's more likely that we would see spread. I think some of it's been kind of like this throughout the pandemic, but just to give people those reminders, I think a big one is family gatherings, and that is, getting together for a dinner party or to spend, a weekend with extended family. Those are situations where we continue to see spread. And it could be, I say family, but it could also be friends. People you know and trust, and you might not feel like it's necessary to mask up or keep your distance or stay outdoors. And that throughout the pandemic has been a place where we've seen spread. Also, part of the contact tracing is I talked about households as being kind of a place where we see a lot of spread. I would say that's probably the most common place we actually see spread, because when you think about it, if there's a family member in a household who's contagious, they're living with a number of people, that's a pretty high dose of exposure to the virus. So similar when we talk about breakthrough cases, it's often that high dose exposure that can be involved. And every time a family member tests positive, it changes quarantine dates for the people who aren't vaccinated. It changes our testing recommendations in terms of when to test. But that's actually, so a lot of the contact tracing is talking through risk reduction strategies for households that have been affected by COVID. We have, seen a number of school cases in the past month, and so when we see that, I think the schools are doing a fantastic job with mitigation strategies. They're also serving a large unvaccinated population at this point, and so really, I think some of it is just revisiting, what are the policies and procedures? Is everything going well? Is there anything we can work together to improve? And I think they've done a good job at following through on that, but that's definitely been a priority area just because I think we are committed to doing what we can to make school as safe as possible, but there continues to be a high amount of COVID spreading throughout the region, and so working on that specifically has been another area of focus. So those are a couple kind of places where we would put extra attention when it comes to slowing the spread of COVID.
So continue following all the safety guidelines.
Yeah, I guess also the large gatherings as well. So going to, if you're considering going to a large gathering, kind of recognizing that there could be risk involved and thinking through ways to mitigate that.
Thank you.
Yeah, I think one of the challenges is that there's a lot of kind of personal judgment, and it can be challenging for people to know how to navigate. In some ways it was simpler when there was the stay at home. Everyone was like, okay, we're staying at home. Now it's a little bit more personal judgment, and so I think just giving information on how people should approach those risks as they're making their decisions for themselves. Yeah.
I don't have a question, but just again, sincere thanks for your focus and your stamina and perseverance and flexibility, adjusting to the changing environment and changing community needs and dynamics and recommendations. So just thank you.
Oh, well, thank you all for your support, for continuing to have me here for updates, and never hesitate to reach out. I'm always happy to talk if there's questions that come up. So thank you.
Thank you.
All right. We can move on to our director's report, staff updates and agency updates.
Try not to trip on my cord here as I get back in. Okay, thank you.
Oh, thank you.
Just want to thank our staff who presented today, provided so much wonderful information to the board, to the public. Thank you all for your support in hearing the stories of the work that goes on within our department. Also really want to thank Sarah Hadley, who isn't here in the room today, but plays a very integral role in supporting the program, the Wilderness Outpatient Treatment Program, and people with substance use disorder in Cook County, particularly as it relates to connecting residents with funding and doing a lot of the technical troubleshooting that we navigated during the early stages of the pandemic in terms of what type of technology platform is going to work, how are we going to get required paperwork to participants, and all of those details that are often unseen but so essential to things running smoothly for the people we serve. I'll try and be brief with my updates today. Starting with staff, we have the retirement of Beth Benson with regrets on the consent agenda today. Really want to thank and recognize Beth for her years of service to the department and the county. We're also, it's our last week with Anita Josiah in her role as an in-home support coordinator. So very grateful again for Anita's years of service to the department.
We are currently recruiting for Anita's position. We ended up reposting that as we didn't have any new applicants referred to us. So we opened back up the applications, hoping to see a list later this week of people to consider for interview for that position. And we'll be posting for Beth's vacancy as well in the very near future. Staying with our adult and home and community-based services team, want to acknowledge their excellent work in their completion of the Department of Human Services lead agency review audit. This is our big audit that happens every 4 years, and are just in the process of finishing that up. I had the chance to participate in the exit review meeting and was able to hear a lot of great feedback on the work that was evident in review of case files and interviews that the Department of Human Services conducted. There was just one minor corrective action cited in that audit related to documentation, and that's a pretty significant improvement over our last audit that we had 4 years ago. So some of the feedback that the DHS staff had to share, and these are direct quotes. They said, "You really know your people." They said, "This is a small but mighty team." Staff are able to establish and maintain relationships. The plans are strengths-based and individualized. They said this is one of the best county examples of case notes that they've seen. Again, probably not anyone's favorite part of their work is documentation, but an important work, and nice to see that recognized. Great coordination with mental health staff and financial workers in coordinating care. The staff were called out as innovative, and that they've done a great job of reaching out to people. So we have a really high rate of people coming into the program thanks to our outreach efforts. So again, just want to recognize those staff for that favorable review from the department. Also want to recognize our economic assistance and healthcare program eligibility staff and case aides. Last week, Governor Walz proclaimed October 13th as County Tribal Financial Worker and Case Aide Day in Minnesota. These staff work tirelessly to connect residents with programs that they're eligible for to support their well-being, including health care, food assistance, cash assistance, housing, emergency assistance, and child care assistance programs. These staff are required to meet very high standards of performance in their duties and determining eligibility for public assistance programs. In fact, just last week, we received notice again from the Department of Human Services that Cook County was one of 18 counties in the state of Minnesota to receive a Certificate of Achievement for reaching thresholds for meeting national timeliness standards for SNAP and cash applications. And that was during the Q2 of 2021 period. Agency updates. Share a few non-COVID related updates from public health. One major initiative underway is our Public Health Fund Review Subcommittee, and I imagine Roger might speak to this in his committee report, but want to give an update on where we're at. We've met 3 times thus far to review both the 2020 year-end grantee applications, so the year-end reports from those organizations that received funding in 2020. And we have also met twice to review the applications for 2022 funding. We had 8 organizations apply this year, and these are nonprofits within Cook County. We have about $80,000 in requests that exceed the amount that we have budgeted for this year, which is one of the higher discrepancies that we've seen in recent years, which isn't unexpected given increased needs that these organizations are serving, but do anticipate some difficult discussions at our meeting on Friday with the review subcommittee as we meet to finalize recommendations, and anticipate having those for your review and consideration at the November Public Health and Human Services Board meeting. So again, just want to thank and recognize the volunteer contributions of our committee members who are dedicated to that process and contribute their time to making those hard recommendations. Another initiative underway within public health is an effort to connect with more young people in the area of mental health promotion and substance use disorder prevention. In the early stages right now of reaching out to others working within the community in this area to learn about the service landscape and planning to reach out to students in the schools and form a youth advisory committee to really learn from young people about what their needs and hopes are in those areas. Also want to give a brief update on efforts underway with the sheriff, the hospital, human services within the county and in Grand Portage to continue to improve our coordinated response to people experiencing a behavioral health crisis. One of the options that we're looking at right now is developing a collaborative proposal that would embed a social worker within our law enforcement and ER and other frontline areas where people are most likely to present when they're experiencing a mental health crisis. We're looking at both federal, state, and regional grant dollars that might be available to support this in a pilot project, and starting to have these conversations with the sheriff and leaders at the respective organizations. The sheriff is pulling data on what encounters he's seeing in terms of dispatch and law enforcement of people who are experiencing a mental health crisis. And there's just a lot of moving parts in that area, as Commissioner Mills knows from his service on our regional boards, but we have a new provider coming in to provide after-hours crisis response. So again, a lot of moving pieces, but really glad for our partnership and efforts to continue to improve that system locally.
Yeah, Madam Chair, I bet there's quite a bit of excitement both from our partners there, just because of what they've seen and the needs of our community, and just from what I'm hearing regionally about other programs that are happening to that end, and how much support there is and how beneficial it is. And I hope we can get this going. I think that'd be extremely beneficial and really help address issues more appropriately too.
Yes. And another key piece of this too will be finding a regional partner in terms of that supervision, that clinical supervision, and in order to make this a more self-sustaining program, certifying through the Department of Human Services so that we could bill for the service. So that's another action item that we're working towards, is finding a partner in the mental health service provider realm.
Might be the trickiest part. Yeah.
Go ahead.
Will transportation be a part of that?
We're exploring that as an option, knowing that that is a major barrier for people right now in accessing behavioral health supports is
And
transportation.
getting them on to where they need to be.
Right, exactly.
Any other questions or comments? All right, thank you, Allison. I appreciate the updates.
Yes.
And we don't have any items for board action this morning after all, so we will move on to our committee reports. Active Living.
Active Living Steering Committee and Safe Routes to School, it was a combined meeting on October 5th. We were very pleased to hear of Betsy Bloom accepting the ship position, and Andrea, and she will be working. I believe Betsy was going to be beginning in November, so we're looking forward to that next meeting and with the two of them, and then they'll transition that. Otherwise, our highway engineer, Robbie Haas, gave an update on his working to finalize the details on the school zone signage, that type of thing. And then on the active living, we had a lot of discussion on the Gitchigami Trail, specifically on coordination needed between the various entities for the downtown area for the signage, and being able to complete that and get, good use of that with good directions through signage that type of thing through the city of Grand Marais. So that's our update.
Thank you. Excited about the signage. I was just in a city on a bike, and signage was very poor. It's very frustrating. So I'm glad somebody's talking about that. AEOA.
Madam Chair, we meet tomorrow.
Okay. And you want to just go to the next one,
Yep,
too?
Madam Chair, no updates on AHA.
Okay. ARC, we had our meeting last week. Good news, they had their inspection, got very good reports, so one of the items that they wrote up about was that in some areas they exceeded their standards. They were very impressed with the programming. It was very comprehensive, so that was very good news to hear. And still struggling with filling open positions. There's quite a few open positions. I don't know what we're going to do with the courts come deal with their backlog and we have more residents and we don't have enough staff. This is getting very concerning all over. Commissioner Svaleson, did you have anything to add?
The only other thing that created an issue for, we did go to remote meetings again because NERC actually had its first case. I mean, throughout the pandemic, it's been amazing that they've not had any issues. And then they ended up having 13 staff, and one of the folks there, the inmates, that actually came down with COVID, and so they had to go into lockdown. They had to stop accepting any people coming in because they just had a very difficult time keeping things up and running during that time period. They have progressed through that now and are accepting people back into the programs, which of course that's what we want. So that was challenging, and then with the issues as well with trying to be able to hire staff, they're having to actually rotate people to accomplish tasks among their various facilities right now. That's the point that they're at, because it's just been very challenging, and they're just not getting the applicants anymore. So we'll just have to watch and see how that progresses, but that's, I agree with the Commissioner, that's very, very concerning right now. That's it.
All right. ARDC.
We're meeting Thursday.
Okay. Community Health Board.
Thank you, Madam Chair. Probably one of my favorite parts of the CHB meetings is the medical expert or member on there, and so and his presentation or just perspectives. And so what he was talking about this time was long COVID, and pretty sobering and ambiguous research there, but more is, we're learning more as things go on here. And just, the fatigue, just the kind of the cough, almost like asthmatic symptoms for longer periods of time. And also, it's also confusing because people can see those types of symptoms in asymptomatic infections of COVID, and as well as asymptomatic breakthrough. It just is all just this big kind of muddle, and it was just really interesting and, like I said, sobering to hear about. I tried to crack a joke afterwards, as I often do, and it was about one of the studies that they found is that somebody who gets adequate sleep during recovery does a lot better. And I said, I wonder if a good diet and exercise also adds to that. And there wasn't many laughs, but I thought it was pretty fun. Because I think it would, of course, we really do need adequate sleep, and that's something not everyone gets. Either we're watching TV or looking at our screens before, and we know that light will and just our brain activity, it takes a while to shut down. So that was probably the most interesting part. Otherwise, one other issue that's pretty relevant to the board here is just that the CHB has a fund balance, much like any organization should. And what we've kind of been trying to work through is that fund balance was largely state dollars. And, the state at this point was not saying we could not do that, but it seemed like down the road that could be an issue. And so the advice from the state was to get a handle on this, get ahead of this. And so what we voted to approve was to dole out those state dollars and then ask each county to pay in to the fund balance. And so a little bit of a monkey business, shell game sort of thing. We also talked about as an option just having one county get the payout and then paying it back in. But then it was, we thought, well, that might be more convoluted and we're all in this together. And it would simplify things paperwork-wise, but some of our staff's perspective was also that, well, once we get this going, then it's not going to be as convoluted. So just got to jump through the hoops.
So how many dollars are we talking that are state
Well,
dollars?
that's a very good question. I don't remember offhand what ours are specifically. It's like 27,000. Does that sound right? Am I way off?
See if I can pull it up in the agenda.
And how, this fund balance then,
And it's by, proportional to our,
right?
Yeah.
And so that, I'm wondering how much money in total CHB is sitting on?
That part, yeah, that's a very good, very
Because
relevant question.
my first reaction is, wait a minute, this money was meant to get out and provide services. So I'm just wondering how big of a fund balance do they have and how much is needed?
Well, yeah, and it's much like any of our fund balances, it's a percentage of your operating cost. But again, I don't know that. But it's a very relevant question, and I betcha I can race Allison here.
Well, if you want to just send that to me later, because I'm probably the only one that likes to look at the numbers.
I literally just saw the document, and it was this one. Did you find it yet? Oh, I'm winning, Allison.
Finding lots of other grant information, but not that one.
Let's see here. It's so this has to do not with its entire fund balance. So that's I'm not going to be able to get that information as quickly, Commissioner Madam Chair. But the total amount was $132,000 for this LPH grant funding, and for Cook County it's $2,800.
Oh, okay.
Yeah. Sorry for that.
All right. No, I'm just.
Exaggeration to a power 10.
Well, it would be nice to know that we had $28,000 that's out there, but yeah, I'm just. And thank you. I'm still working through how all these things work together. So
I thought, well, it's funny because I thought I had a pretty good handle on it when we were talking about it in smaller groups, and then when Susan Michaels, our director, sent out the document for the different scenarios, then it just like spun my head around. Wait! I thought I had a good handle on this. So, I think there was fear just about because we had discussions about which counties would even be participating in the CHB not too far back when we did our director search. And so I think there was some sensitivities and just worry that this would shake things up in that regard. But it was a very, I don't think there was really any risk there. Everyone seemed like we were on the same page, and it was just how best to jump through the hoops. Do we all jump through a hoop, or does one county jump through a bigger hoop, or, that sort of thing. So. But it was a good discussion, good team effort. And I think that's all I have to report on the CHB.
All right, thank you. Next, we have the LAC.
All right. So we met last Tuesday, and we have finalized our vision statement and mission statement, which are big things we've been working on. And Allison, can you give me the wording on that, because I didn't bring those.
Absolutely. So the vision that was selected by the council is the Cook County Local Mental Health Advisory Council envisions communities, including the Grand Portage Band of Lake Superior, Chippewa, and Cook County, where mental health is understood, valued, and supported.
Good. Thank you. Yeah, it was important for us to include Grand Portage as a community to make sure everybody feels included and is included. And then the mission statement, do you have that?
I do.
Yeah,
The
okay.
mission statement is the Cook County Local Mental Health Advisory Council seeks to remove barriers and increase access to mental health resources for all community members. Council members strive to enhance the work of the Public Health and Human Services Department, advise the Cook County Commissioners, and improve the mental health system and services for the community.
All right. Thank you. So, as I say, we've been working on this. Other things that we talked about were the schools, and I'm not sure if it's all the schools or not, but Carly Puck has been doing mindfulness Mondays on the radio, and now she and Andrea, I think, are working in the schools to help children with mindfulness and relaxation, and I think that's a very important prevention and early awareness of mental health and mental wellness for people. So, that will prevent in the future having more issues. Just saying, everybody needs this. We're all, this is good for everybody. These are skills you can learn, just like math and reading. So I like that. And then we had an update from the employee well-being design team, which is the county employees, and we heard of good working relationships, but that needs to be created and worked on by people, and there has been some extra stress on everybody this year, as we all know, so it's important to keep working on that and make sure people are able to do their best work, do with the environment that helps them in the county. So that is something that is going on, and I think that is about it. Everybody, I know in the clinic, James is one of the people there who does mental health, and just because of some other people being out for different reasons, he's had to take over more cases, and so he's been doing that and helping pick up the slack from some people who couldn't be working right now. So, is that okay? Anything else I missed? No? Yeah.
I wouldn't say
Yeah.
there's anything else, but just to kind of lean in on that a little bit, with the vision, the really understanding mental health was something that I thought was really important with that, and some of the discussions that had, because a lot of the group is kind of in the mental health realm, and so part of that is to really expand that realm and make it accessible for everyone to understand and not have it. I think one of the phrases is not so jargony, which I think we can all appreciate when it comes to acronyms and that kind of stuff. So I thought that was, and I think it's just it was a really long process, but a really good outcome, I thought.
Mm-hmm. Yeah, and we do have people on the committee that are not professionals, or and they're especially very concerned about using words that everybody can understand and really mean something instead of jargon.
Yeah.
And I think we were able to do that.
And also with the school side of things, that was, when I was on my soapbox earlier, that was what I was trying to get at, is developing these positive habits that can lead to positive addictions, just those positive pathways. And so to be able to, help kids learn how to, this window of tolerance is new to me, so I'm using it again, but to expand the window of tolerance, I think is just a really powerful tool. And so to get that in the schools at an early age, it's just very, very exciting. So I hope there's success there, and I hope it really catches on and is integrated more and more, but we'll see. We certainly have talented individuals working on it, so.
Thanks.
If I may, I have another relevant update from our Mental Health Advisory Council. On the consent agenda, you approved the appointment of a new member, Kristen Hale, who is joining us on the council. She is a mental health provider, formerly with Ascend Services. So on one hand, this is a change in staffing again at Ascend locally. Kristen was really tasked with rebuilding the team here in Cook County and Grand Portage, and with her departing from Ascend, that leaves another transition and uncertainty about services. Kristen did share, however, at our meeting that she's joining a new practice, MAP, Behavioral Health Center out of Duluth, and is working on expanding services up the shore. So Kristen was wanting to stay engaged with what's happening locally and how she in this new role can help address gaps locally.
Thank you.
Thank you.
Restorative justice. I was not able to attend the last meeting, but I apologize, I'm not as quick as Commissioner Mills. I had it open, but it closed. So my notes are going from memory. New program starting up at the school. That's kind of exciting. And as far as truancy, I think they're trying to work with truant issues. There was a gathering at Grand Portage, and I can't remember exactly what they were. It's circle training. And there's a new case that's been referred through our court. So they're active and they're looking to do some more work. And I have another meeting Thursday, so I'll get caught up. And I'll keep my notes open next time when I report. I apologize for that. Council on Aging.
Well, the Council on Aging met on Monday, October 11th, and as I mentioned last month, they were working hard on their bylaws. They did approve a new set of bylaws, or revised bylaws, and have expanded the number of people on their board. So they are hoping that they will have, and they already do have some applications that have come in, but expanding their board by up to 3 people from what they currently have. And those positions would be available starting in January of 2022. So very excited to be moving forward in such a positive direction.
Thank you. Healthcare Planning Committee.
You jumped emergency.
Emergency preparedness, sorry.
Oh, yeah. And probably long and short is just what we heard from Grace. There's updates beyond what we heard then, but just very sobering of what's going on in the community as far as the SPED, but also very encouraging with the contact tracing and the success there, and just the school's willingness to participate. I feel like there's just reinvigoration or a recommitment by the schools in their participation. So I just really appreciated that. I don't know if there was.
They did a little bit of a fire update, just talked about kind of the cleanup for the Greenwood fire, and just looking at big projects that will reduce fire danger in the future. The Twin Greens project, which will be over the next 10 to 15 years up the Gunflint Trail, is going through scoping right now. So that'll be a big piece.
Okay. Now, Commissioner Storlie, you get the next 2.
Thank you. Well, this was unusual because I was in the car, so I couldn't take any notes, not even many notes, but no notes. However, I was excited to hear that there is now going to be a physician from St. Luke's coming up to the clinic and going to be helping with some minor things that are going on, no major surgeries, and it was written up in last week's Cook County paper, so thought that was pretty exciting. Otherwise, everybody's moving along in their departments, doing what they have to do and beyond. So, thank you.
And NACO?
Okay. I'm going to just briefly, for the new folks here, just give you a little background. Twice a year, all of the counties get together in different district meetings, and we're number 1, just because that's what we are, is 1 and it goes down. So AMC meets with all the folks in Minnesota, and they start with us. And so we have a list of priorities. And we have a ballot, and the ballot then has the different general government, environment, public safety, and so we rank it. What's important for AMC to support in all these areas? So in the end, in Health and Human Services, they're quite concerned, and this was the top issue, the closing of Moose Lake, which was back in the 90s, and there was money left over from that. And the state is now quibbling about how that money is to be spent back to the counties. So evidently, and it's not one that I voted for, but evidently it is a big deal. So that will be the platform that will go into in December when we go to the full 87 county meeting down in the cities. So it's just interesting how, how all this works, because things rise to the top that's important in one area and then not so much in another area. But AMC, will be supporting this. And then there'll be other issues that we'll talk about too, I think, in December. But that's how all that works.
Thank you. Northeast Minnesota Office of Job Training.
Thank you, Madam Chair. Nothing to report there. Moving on to the next one, North Shore Collaborative. Nothing to report other than that. And I'm not even sure if the application period has passed. I don't think so. I think it's fine up until our next meeting here. But there's a substantial balance for grant that we dole out in the North Shore Collaborative, and I think it was like $55,000 left. And so I just want to encourage any community partners that are listening, and I know that there's been some outreach with some already to apply for those grants, and we can evaluate and get the money out into the community. So, but the meeting I think is next week.
Thank you. And last but not least, Roger.
Thank you, Madam Chair. As Allison alluded to, the subcommittee is working on the grant process for the funds that are provided by the commissioners. And I see Pat's here too, so if she wants to jump in and make some comments, she's certainly welcome to. It is not an easy task. When, as Allison says, there are 80,000 more in requests than what we've got to give. A couple of the requests have increased a great deal over the past year. So the group will be working very hard and I guess I'd say courageously, to bring everything down so that everything fits within the amount of money available. It's really hard. It's really hard because you can see the need for each group. Each group has a need, and to be able to put it all together so that we can meet the needs as best we can. And you'll find out in November how we do.
So any of those organizations, could they apply over here?
There was one I was just thinking of that could do that, I think.
Okay.
That we will discuss that Friday, I'm guessing.
And I did send the grant announcement out to all of the applicants so that they were aware that that was an additional funding opportunity. And there are grants are reviewed quarterly. So even though we might not have a recommendation yet to them for 2020 funding, it is something that they could explore applying for in January. I believe would be the next application review by the collaborative.
And a number of the groups that I'd say most of the groups we're working with are already receiving funding from outside, some more than others. But it's the way to go. I think that's what I got.
All right. Thank you very much.
You're very welcome.
All right. Anybody else have anything that they want to share we've missed? Something? Go ahead.
Well, we heard from all the successes and strengths of our staff, and I just want to recognize Allison for leading such a great team and such great staff and your hard work, and you're often giving kudos to everyone, and you deserve it as well. So thank you very much for your work and your leadership and just having the vision, your flexibility, and really trying to help our community. So thank you, Allison.
Thank you, Commissioner Mouse.
Yes, I think we all would agree with that, and I appreciate Allison's patience with me with all my questions and trying to understand everything, so, yes. We have a good staff.
Yeah, thank you.
All right. If nobody has anything else, we've got a couple minutes before our next meeting, so do we have a motion to adjourn?
I'll make it.
Thank you. Do we have a second? Thank you. All those in favor?
Aye.
Aye. Those opposed? All right. Thank you very much.
Thank you.
I'll see you in a month. I'll see you in a few minutes.
Few minutes, yeah.
So, that's the presentation we had last time. Okay. So, today's presentation we won't get till next time.
Correct, but if you want the PowerPoint,
Well, because I go to township meeting, I took notes today, and I think I'm okay with it, but it does change, of course. So, should I just always request it, or?
How are you doing today?
Very good, how are you?
Oh, I'm doing well.
Good, I would, yeah, I really would, because then when I go to the township.
Really enjoying this fall weather.
Yes, isn't it gorgeous? Really much in the health area. I do a little bit